So CNS leukemia was very, very critical back in the 60s when we didn't have CNS-directed therapy. Like 80% of all patients would relapse in the CNS. So everybody introduced initially first irradiation, we're getting away from that, and now we're giving the thecal therapy, either methotrexate or triple. However, our diagnostic approach has been inferior. So it's quite difficult for pathologists to identify leukemic blast in the cerebrospinal fluid when they do the cytospin. And the reason for that is that cerebrospinal fluid is very cytotoxic. So the cell doesn't look normal. It's not like you take a bone marrow and the pathologist can look at the cells. When you look at them in the cerebrospinal fluid, it's very much more difficult to detect. It can both mean that they have an underdiagnosis, but it can also mean that sometimes you see cells that are in some way looking odd because it's been exposed to the cerebrospinal fluid, and the pathologist may not know exactly whether this is a leukemic cell or not. So we have for, I don't know, many, many years, 10 years, 15 years, been monitoring leukemic infiltration or leukemic presence in the spinal fluid by flow cytometry. It's very, very sensitive. The median level among patients is 28,000 cells per liter compared to a 1,000-fold higher level when you just look at normal cells. So you really need the flow to dissect these. And furthermore, when you see those patients that are positive, they have like a 3 to 4-fold higher risk of developing relapse, not just in the CNS, but also in the bone marrow. So in the current protocol we are now running in the Altogether consortium across Europe, we are integrating flow cytometry in the early diagnostic phases, you could say, to support what the pathologist finds. So even if the cells just look odd, he's in doubt whether they're leukemic. And also when he thinks they're leukemic, we require flow cytometry to validate that. And that will then subsequently stratify patients to various CNS-directed therapy.